Parenthood in medicine has primarily been seen as an inconvenience rather than a part of life. And unfortunately, parents do face a lack of career advancement, exclusion from job and training opportunities, negative referral patterns, resentment from colleagues, especially throughout training. And we have shown with Ontario level data that this has led to a delay in childbearing for those who are in medicine. We found that female physicians were less likely to bear children between the ages of 15 to 28, more likely to bear children over the age of 37, and specialist physicians were less likely to bear children during training. And this isn't necessarily concordant with what physicians would have wanted their family plan to look like, but a career in medicine kind of changed their views. And so there are many physicians who have said that they would have tried to consider conceiving earlier. There are several physicians who would have chosen to preserve their fertility. We do see that there are higher rates of infertility, miscarriages amongst female physicians, and female physicians are more likely to experience complications of pregnancy. And in our data, this was primarily related to advanced maternal age. And overall, we know that medical training does fall within the years of optimal fertility, but medical students and residents generally have limited knowledge about family planning and age-related fertility decline. So these are the things that I think are essential to ask yourself if you're in the midst of thinking about what your family plan could look like throughout your life. And it's important to think about these questions often and early. One, of course, is do you want children? Another way to ask that question is, would you be okay not having children within your lifetime? When do you want to start having children? How many children do you want? Will your age while your children are growing up matter to you? Is having a partner before having children important to you? Is it important to have children that are genetically linked to you? Or would you be open to things like donor egg, donor embryo, or adoption? Are you able or willing to provide egg, sperm, or uterus to support a pregnancy? And will you have a partner that's able to provide any of those gametes or a uterus to carry the pregnancy? These are additional questions to think about if you're in a same-sex couple, but things, importantly, are you able to provide any of the gametes? Are you willing to carry a pregnancy? Is your partner willing to do so? And if not, is there someone in your life that would be able to provide egg, sperm, or uterus to support a pregnancy? These are some other questions that we think about kind of, you can still see my presentation?
Yes, I can still see it.
Oh, okay, sorry, it just popped away on my screen. Other questions to think about kind of fitting a family into your life or fitting children into your life is, how will starting a family impact your career? Are there any adjustments that you'll need to make in your work schedule or job responsibilities to accommodate a child? What are your financial goals? How will starting a family impact your budget or your lifetime financial goals? Your relationship may be an important aspect as well. How will starting a family impact your relationship? Are you prepared to make the necessary changes to your lifestyle and daily routines to accommodate having a child? And what sort of support is around you, especially in medical training and in practicing when we find our jobs or find positions that are available? Is that going to be close by to people who are going to be able to support you? Is it potentially also going to be a big enough community that childcare is available to you in that region? Now, when I see patients, this is a little bit more of the medicine aspect. People get worried about the age of 35, but it's important to understand that 35 is not, you don't wake up on your 35th birthday and everything is over. That's just when you should really have kind of a solid view of what your family plan will look like over the next few years, because there is a gradual increase in the risks of infertility, miscarriage, genetic disorders, pregnancy risks. It becomes much harder to conceive after the age of 40, and it's very unlikely to conceive after the age of 44. So this is some data from IVF, and it's important to understand sometimes people believe that IVF can overcome age-related fertility decline. But with birth rates with IVF, it's still quite low after the age of 40 and after the age of 44. When we're thinking about family building, now these are kind of some just kind of pearls to think about. One is that people often ask about fertility preservation. When is the best time to freeze eggs? Should I freeze embryos? Should I freeze sperm? And what I generally tell people is that the egg quality and quantity is stable until the age of 32. And when they have done cost effectivity studies, and when they look at those studies, what they're trying to quantify is the number of people that are going to need IVF to conceive because they're struggling after the age of 40. And when they compare those costs to the costs of egg freezing, they find that the best time in terms of cost effectivity and age-related fertility decline to consider egg freezing is around the age of 35 to 37. The decision to freeze eggs and embryos is not as straightforward anymore. There used to be old advice that embryos are better than eggs, but that's no longer really true as we've changed some of the freezing methods. And so the reality is that you should only freeze eggs if you're trying to preserve your reproductive autonomy. Once the eggs are tied to sperm, they're forever tied to that sperm. And often when people are thinking of fertility preservation, they're often thinking of using their gametes with a partner in the future. So if you freeze an embryo, that becomes much harder. When people start trying to conceive, that's a very stressful time for people, especially for a lot of us physicians who are type A personalities and like to plan things to the T. But the reality is infertility is only defined as 12 months of trying and not being successful. 85% of couples will conceive within a year, and within the first 6 months of trying, about 75% of couples will conceive. The other options for conception that are important to know about are things like donor gametes, so donor eggs, donor sperm, having a gestational carrier to carry the pregnancy. The other option is reciprocal IVF for same-sex female couples, so you can use one person eggs and one person carries the pregnancy, and adoption is an important option when we're thinking about family building as well. Now, the costs around some of these fertility treatments can be things that people often ask me about. So when we're thinking about egg freezing in terms of the costs of that, it's generally about $8,000 with a storage cost of $500 to $900 a year. The medication costs cost between $3,000 to $8,000, and the average, I would say, is about $5,000. Now, if you are in Ontario, Paro actually will cover, and you're a resident, Paro covers 100% of your fertility medication. If you are in Ontario and you are a practicing physician and you have OPIP, you'll have $7,000 that you can use towards fertility medication. So that will often cover medications for 1 to 2 rounds of whatever treatment you're doing. In the future, when you choose to inseminate the eggs to create embryos, there are costs to that as well. So inseminating the eggs is around $3,000, and transferring each embryo is around $3,000. But you can potentially retroactively apply the Ontario government funding that's available for IVF for use towards the eggs that you had frozen in the past to create embryos and then transfer embryos. So those are some of the things that you can discuss with a fertility physician if you are requiring that treatment. In terms of the time commitment, that's about 4 to 8 weeks in terms of meeting with somebody, doing preliminary investigations, and then actually getting started with a treatment cycle. When people ask about embryo freezing, this is what is called IVF or ICSI. So what that means is it's referring to the fertilization of the egg. So you can do it in vitro fertilization where you're mixing them in a petri dish, or you could eject each egg with a single sperm. In terms of the procedural costs for something like IVF, that's about $15,000 to $18,000 a cycle, depending on the clinic. There's storage costs of $900 a year or so, and then there's the same medication costs. And all of those things I told you about Paro and OPIP would apply towards these medications as well. There's some additional costs, and when people are thinking about embryo freezing, they're also thinking about potentially testing the embryos to make sure that those are normal embryos that they can use in the future. And when I say normal, I mean chromosomally normal. And you can do genetic testing on embryos to do that, but there's an additional cost of about $5,000. So these are some of the costs that are associated when you're thinking about fertility preservation or using this as part of your tool of family planning. These are I just put some of the other costs that can be associated with fertility treatment because people often want to know about cycle treatment and testing and things like that. So these are some of the costs that can be associated when you get involved in fertility care if you need to access those services or you're thinking about fertility preservation. In terms of same-sex couples, it's important to understand that family building takes time and there are other expenses that can be associated with it. It tends to be faster for non-identified frozen gametes, so the access to donor sperm and donor eggs in a frozen bank tends to be faster and easier to obtain. But you can also use fresh donation depending on whether you have somebody that's willing to undergo stimulation for you or if you're finding somebody through an agency to do that. In terms of costs that can be associated with that, it's about $1,600 for a vial of sperm, and you need 1 vial per treatment. So you need 1 vial for an insemination process, 1 vial for an IVF process. Donor eggs are expensive. They cost between $15,000 to $40,000, depending on what program you're signing up for. So that's an important thing to budget if you're in a same-sex couple where you may actually need to use donor eggs. And it's important to understand that different clinics can support you in different ways. So some clinics will only use egg and sperm banks, and while other clinics are willing to work with agencies and surrogacy. So you do need to call some of the clinics and find out what they're willing to do in order to support you. You will also have some legal costs that are associated with that. So arranging for consultations with a lawyer can cost up to $1,000 to $2,000. And then there's often some genetic testing and counseling requirements that can be associated. So when you're thinking about that and you're budgeting for family building and you're in a same-sex couple, these are the costs that you often have to keep in mind as you start your budget. So now we're going to switch gears a little bit, and I'm going to talk to you a little bit more about parental leave options that are available to physicians and available to residents. And we'll start with kind of what is standard for the employment insurance benefits available to residents. Now, I noticed on the form that we have some people from out of province as well. The things that I'm talking about are primarily Ontario related, but we do have a website that's called familyplanningfordocs.com. And on that website, you will find links to every province, including residents associations and physician associations and any sort of information that could be related to parental leave benefits. So although this has an Ontario focus, the website does have access to all of the other groups, and we did also put how to think about those kind of leave benefits as well. In Ontario, when you're in a residence or salaried position, to access EI, you need to have worked about 600 hours before you can activate it. So in general, this is usually achieved by about 4 months of residency before you can actually access the EI benefits that you'll need while you're on parental or maternity leave. And you do have access to maternity leave for 15 weeks for the birthing parent, plus the parental leave, which is an additional 35 weeks to that initial 17 weeks. And in terms of the actual amount that you receive 55% of your average weekly earnings to a maximum amount, which ends up being about $650 in 2023. The other thing that's important to know is that according to EI, it does not have to be a consecutive leave. So you could technically work for 2 months, take leave for a month, and then work for another 2 months. However, the Employment Standards Act does not necessarily allow non-consecutive leave. So this actually ends up being up to your employer, which is the university, as to whether you're allowed to take non-consecutive leaves. So that's an important thing to discuss if you're thinking about doing that with your program director and potentially with the Office of Learner Affairs, or potentially with your someone more senior in the payroll, et cetera, as to understand what the university is going to allow you to do. Importantly, if you are the birthing parent and something happens during pregnancy, you should not activate your maternity leave. You should use sick leave. Now in Paro, you can actually use up to 6 months of sick leave, and that's in Ontario. So each province is going to have a different stipulation specifically for residents, and that allows you to access a little bit more of your income actually during that time. The other thing to note here, especially for the learners who are present here, is that many fellowship programs are not included in Paro and are under completely different contracts. And you have to read the contract to find out if you're actually eligible for something like EI, because oftentimes you're not signing a contract as an employee, you're signing a contract as an independent contractor, in which case you do not actually get access to EI. And you may not actually get access to benefits, and your contract may state that you aren't actually able to take leave. Now, officially, under the ESA, you can take leave. It just will have to be unpaid, and it'll have to be discussed with your program. So there are special considerations for fellows, especially when they're not included under Paro. In terms of practicing physicians, now across Canada, there are different supports for practicing physicians. So again, I focused on Ontario on this slide, but over on the website, you can find links to all the associations, and many of them do have parental benefits for physicians. In terms of the parental benefits that are available in Ontario, this applies to practicing physicians who have been practicing for 26 weeks prior to their leave. And they basically will calculate the amount that you can earn based on that. And the maximum that you can earn is about $1,300 a week from the Ministry of Health for 17 weeks. And each parent actually gets access to this. So initially, interestingly, it was only for females, but this was challenged by physicians and it was changed to apply to all physicians, which is great. So each physician parent can have access to that 17 weeks. You can also actually earn a little bit while you are on that leave program. So you can have a payout of an additional $1,300 in order to access the $1,300. Now, importantly, you can't earn more than $2,600. If not, you won't access the $1,300 at all. All of the stipulations are on the Ministry of Health website, and actually they did a big update in June of 2024, which has a lot more of FAQs on there. So if you go and actually read them, it's pretty informative in terms of what you need to do to access these benefits. And nowadays, what I've noticed is that a lot of the physician contracts that you sign, so for example, I sign a contract as an independent contractor with my clinic, but in the stipulation, they actually will top me up with my salary for a maternity leave, but they will pay out the amount that still allows the Ministry of Health to pay out the full amount of $2,600 or $1,300. And I've been supporting the Department of Surgery and the Department of OB/GYN in kind of rethinking the way that we support practicing physicians and parental leave. And one of the things we're trying to structure is allowing a little bit of payout from a department or from a hospital while still allowing the physician to access this money from the Ministry of Health. So some of these stipulations are important, but these are some of the things that you might think about if you're part of creating that policy as a physician in a department, or if you're thinking about accessing that policy. Now, the other thing here, and I have one of Steph's slides up here, is that if you are incorporated, you can actually choose to control how much you're paying yourself out of that corporation. And you may also take into account that PBLBP or that benefit that you can access, because you'll want to pay yourself out a small amount so that you can actually access that benefit over that time. And so what you can do is just smooth your income so that you're paying yourself out the same amount over a certain amount of time from your corporation. And this would be specifically if you're incorporated. Okay. Now, the other thing to think about, especially as if you're kind of a newer physician or you're thinking about changing jobs, is that we are seeing more parental leave being included in a lot of the departmental jobs. As I mentioned, I am working with the Department of Surgery, the Department of OB/GYN here at the University of Toronto to start thinking about this and incorporating this. And so it's something that people are thinking about. And when you're looking at your contract, the things that you can look at is understand the terms of your leave. So how long do you have to work before you're entitled to leave? If you're salaried, are you going to receive a top-up payment? How will this impact academic progress if you're an academic physician? Do you have to find your own locum? Are there rules in your group about what your locums can do? Some locums aren't able to do call, which makes the locum potentially less attractive to some candidates, so something to think about. Will your group cover call for you if an emergency happens? Are you going to be responsible for any overhead charges? What about license fees, society charges? Are those things that you're paying for, they're paying for? Does it pause? And what are your expected work hours, and can that modify on leave when you're coming back, etc. The other considerations that people think about when they're thinking about jobs are, what are your available childcare arrangements where you are? So I've heard of some people being in a small community, for example, and they're expected to set up their own daycare. So they're given some funds to set it up, but they have to hire the person, they have to find a space, etc., all so that they can have a child. So that's something to think about. And especially if you're in the process of finding a job, you're talking to a recruiter, these are questions that you can ask, like, what are childcare arrangements? What are the daycares like in this area? What are nanny availabilities like? Are there any stipends for any sort of things like this to attract physicians to that community? And that can be important to the smaller of the place that you go. The other things that people think about are, what are the schools in that area? What are your work hours going to be like? What are your proximities to your support systems? For example, if there's unexpected illness in you or a family member, etc., what's going to happen? Will there be someone available to help you watch your child or manage your work responsibilities? Are there opportunities to explore leadership roles in academic settings, which sometimes allows for more flexibility in your clinical work? Is there going to be protected academic time, or are you going to be expected to do these things after your clinical work time, which may impact your family time? So those are sorts of things that people think about when they're starting to look for jobs. They're starting to apply for jobs. Okay. Now, I briefly mentioned some of this before, but just to kind of be clear about what supports you do have in terms of the insurance availability for family planning, family building, and parenting. In Paro, again, this is Ontario-centric, but on our website, you can find links to all of the other jurisdictions. In Paro, there are EI top-ups for the birthing parents at 84% of your income for 27 weeks. So non-birthing parent, it's 84% of your income for 12 weeks. There are overnight call limits to stop at 27 weeks gestation. There's breast pump coverage. There's fertility medication, 100% coverage. All of your benefits continue on leave, which is really nice. So your health and dental benefits will continue. Some provinces actually stop the benefits and you have to pay payments if you want to continue them. The other nice thing is vacation time will accumulate and you can take it together at the end of the leave. So for example, I had a 9-month mat leave. I added on an extra month, so I actually had a 10-month leave and I was paid 100% in the last month because that was accumulated vacation time. Upon return to work, you must be accommodated to chest or breastfeed or express milk. So that's really important. When you're coming back to work, you do have the safety in the environment to do that. Now, OPIP, which is available to Ontario physicians, there's $7,000 in fertility medication coverage. There is coverage for a lactation consultant for 2 hours and a birth coach for $1,000. The other question that sometimes people ask is about the impact on Royal College exams or fellowships. So this is again directed towards the trainees. There's actually no longer a restriction on when the Royal College exam can be taken in relation to the end of the training. So you may hear from residents, fellows, or staff that they only took 6 months off or 4 months off so they could take the exam with their cohort, but that's no longer applicable. So you can take it anytime, provided your program director approves that you can take it at that time. The only thing to keep in mind is that sometimes people will take the exam for it's only offered in June, but technically they finish their residency in January and they can't get a license. And so there will be 4 months of no payment during that time because the residency program will not extend. So what you should do in that situation is extend your leave, actually, so that it's going to cover you all the way until the time that you're taking the exam. So that is something to keep in mind in terms of leave length, residency end length, and exam timing. The other thing to keep in mind is that because fellowship programs are not necessarily regulated, the Paro programs will have no problem with sort of leave timings and starting off cycle. But all of the programs that are not necessarily Paro covered may have specific times that you can apply and application cycles that they're willing to accept your application for. So if you're off cycle, you may not be able to start until the next July. The other thing that people often have to think about is finding a locum. So that can be very important, especially in family medicine or if you're in a small community. These are sorts of different strategies that you can use in order to try to find a locum for yourself. And I encourage you to start finding a locum early if that's something that you need to do. And again, you'll find that out from your department, from your contract, etc., if it's something that you need to do. And on our website, you can find a little bit more information about how you may construct a locum posting. There's more information also on the CPSO website. You can choose when you're trying to find a locum, there is actually support through the OMA. And so you don't necessarily have to pay lawyer fees. You can have a contract review with one of the OMA lawyers, which can be really helpful. And if you're thinking about a locum, the other things that you do have to think about as you are constructing your job posting is how the finances will affect you as well. So how much of the overhead is the locum going to cover? How much of the earnings are the locums going to get? Things like that. Those are all the things that you have to start to think about when you're constructing that contract. And you'll have to understand kind of what the other physicians in the practice or group want in terms of stipulations around your locum. Okay. And then in terms of kind of thinking about you're just about to go on leave, what are the things that you might start to do for yourself? Many people will choose to meet with their financial advisor. You'll need to discuss your plan for your leave and return to work in detail with your partner, with your program, with your colleagues, etc. Things that can help kind of save money over time is deciding whether you're going to continue CPSO or CMPA coverage. Most of these things can be paused while you're on leave. You can think about what administrative or academic duties you're going to be performing on leave. Sometimes there's a stipend for some of these duties, and you'll want to work that out with your PBLBP payment or your whatever payment you're receiving from your association or your government. And then you'll want to advise your colleagues and your staff how you're going to be reached, what's your preferred form of communication, what you're willing to be asked about, do you want to be included in invitations for meetings, rounds, administrative activities, etc. Okay, now sometimes people are unable to find coverage for their practice, and that is understandably extremely stressful. But the reality is you'll have to close your practice. So there are practice closure guides. OMA has a guide, CPSO has a guide, CMPA has a guide. And so you'll have to think about whether that's something you'll have to do in the event of a leave that's upcoming, a maternity leave or a parental leave, and how that's going to work if you don't have coverage for your patients. Okay, so now we're switching gears again. So now we're thinking about coming back to work and parenting. So we went through family building, family planning, going on maternity leave, parental leave, and now we're thinking about coming back to work and being a parent. Some of the things that we think about are childcare. So when you're thinking about childcare, there are generally 2 to 3 options. So you have a nanny, part-time nanny, you have daycare, you have home daycares or institutional daycares. And then you have family care if you have family that's available to do that for you. When we're thinking about nannies, they generally are the more expensive option. They're $21 to $25 an hour, depending on full-time, part-time, etc. Also highly dependent on the area you're in. So you'll want to find out from people around you what the going rate for nannies are. So the rates in Toronto, for example, are different than Hamilton. Now, generally, nannies tend to talk about these things as net income. So they talk about, wanting 800 to 900 a week, and you need to calculate out what that actually is gross with taxes, etc., and hours worked. So sometimes people will say, I'm willing to work 50 hours for 900 a week, and then you have to calculate out what that would actually be on an hourly basis. In general, nannies cannot be paid for through your corporation, so that's often a question, is can I structure it so my nannies are paid for through my corporation? And the answer for most accountants is no. This is like a personal thing that you have to pay for. There are payroll services that can help you with sort of associated taxes, EI, things like that for the nanny. Some people choose to pay their nannies cash, and some nannies prefer cash. So that's something you have to decide if you're comfortable with. I would say most people are not comfortable with that. And you just have to figure out kind of what you're doing and what your nanny is doing. The other thing to think about with nannies is support on sick days. So if your nanny's sick, if your child is sick, what are you going to do? Are you going to be able to take time off? Or do you need some sort of backup system in place? Do you need a backup nanny? Do you need a backup babysitter, backup family? If you're somebody and you're in a partnership where both of you have overnight call, you may need people who are willing to do some overnight call. Sometimes people also have to have multiple overlapping nannies. So one nanny working 8 to 1, another nanny working 1 to 8, another nanny working 8 to midnight. So these are things that some people have to do depending on their working hours and what they do, and overnight call help. Daycare is much less flexible than a nanny, but cheaper, much cheaper. So there are all sorts of talk about daycare strikes if you're following the news, because the daycare workers do not like the new Ontario program, and this is Ontario specific, about the $10 a day program. But we are starting to move towards that. The problem is not all daycares are included in that, and home daycares are not included in that. So daycare costs, if they're not in the $10 a day program, are closer to $2,000 to $3,000 a month. If they're on the $10 a day program, then that's obviously much better. The other thing to think about is that daycares often send your kids home with the slightest sign of a runny nose or an upset tummy or whatever it is. And so many people need a backup system because the daycare decides on a lot more sick days than you may decide on. The hours are less flexible. There are wait lists. You generally have to join as soon as you know that you are pregnant, and you have to be on multiple wait lists, because the reality is that daycares are often in high demand, especially the ones that you want. And a lot of physicians choose to have a part-time nanny or a housekeeper in addition to a daycare. So you'll have to work that out in your finances depending on what's available to you. And then the other thing to think about is when your children are school age, There's after school care. So school generally ends at 2 to 3 p.m. And there are a lot of after school programs which will cover childcare from 3 to 6 p.m. So then you'll have to think about which programs you're going to sign your children up for, what the costs of that would be, whether a part-time nanny makes more sense, and how you're going to structure that if you have a partner or family supports around you. Some of the options for overnight or last minute childcare help are babysitters in your community. You can also choose to post on Facebook groups or CanadianNanny.com, and there are some emergency nanny services, but even in Toronto, which is a big city, these are actually very hard to find. Okay. Now, nowadays, pediatricians recommend that breast or chest feeding occurs for up to 2 years of a child's life. So something that you may need to work into your clinical day if you are somebody who's choosing to breast or chest feed, and think about kind of budgeting 20 to 30 minutes every 3 to 4 hours. This will become shorter as your child becomes older. Work that into your clinical schedule, plan your route to your lactation room. And if you're covered under Paro, breast pump coverage is coverage. OPIP does cover a birth lactation consultant. So these are things that you can think about if you're trying to plan those kind of 2 years back to work after your child is born. In terms of thinking about your work schedule overall, you want to think about your ability to return to work part-time, your ability to change your schedule or some aspects of your usual job duties, build in time for lactation if necessary, consider the options for virtual or phone care if some of that could be done from your home, and opportunities to reduce your administrative burden so you're spending less of your family time working on those things. And then also some people are more and more thinking about practice splitting a full-time job with another practitioner and then slowly transitioning into a full-time position. The other kind of startup costs that are associated with having a child, people often think about buying a home, a bigger home. That can be a consideration. A car, often when you're transporting kids around, it can be hard to rely solely on transit. And then those kind of big tickets items like your crib, your stroller, your high chair, and then those ongoing costs like diapers, extra food, formula, clothing, etc. Now, in general, a lot of the big ticket items you can purchase secondhand to save costs and also sell them when you're done using them because these tend to still go for a reasonable amount. So a lot of the things that I have actually, a lot of the big things like the high chair, were purchased secondhand, and like things like the crib were purchased from IKEA. So there are ways to cost save here in terms of your startup costs. As you move on in life and as you start to think about your financial planning, the other things to think about are having life insurance as soon as you're pregnant, for your children in order to support them given the high amount of debt that a lot of us have. So a lot of us will think of having term 10 or term 20 life insurance for 1.5 to 2 million to think about covering our children so they're not burdening our debt if we were to pass away, of course. The other thing to think about is setting up your RESP for your children as soon as possible so you can take advantage of the Canadian Education Savings Grant, which is about $500 a year, provided that you're contributing about $2,500 a year. And there's a $50,000 lifetime limit to these. The other thing to think about is if you're going to have multiple children, sometimes people will get a family RESP so that any child can use that rather than an individual child, but you can make that decision after your first child as well. There is a podcast episode from Beyond MD. It's I can't remember his name, I'm so sorry, but he does a lot of great financial podcasts, and he does have one recently that's all about RESPs. So if that's something that you're interested in or learning about, then that can be a good option. And then the other thing is that you do receive the Canadian childcare benefit from the government, and that's $5,000 to $7,000 per child on your taxes, depending on the age of the child. But this is income dependent. So technically, if you are the higher income earning spouse, and that would be from your corp, like what you're paying yourself out, then you may not be able to claim the full amount, but your accountant would be able to help you figure out what you are claiming and which spouse to claim it under. And other kind of lifestyle, lifetime costs that are associated with having children would be things like schooling. So thinking about what sort of schooling is important to you, private school prices in your area, public school is free, of course, extracurricular activities and what your budget is for kind of those things. Is your child going to do piano or soccer or violin or whatever it is? And then healthcare costs. There can be many sort of healthcare costs that are associated with children that you do have to keep in mind as well. Okay, that is the end of my presentation. I think I'm almost at my 45 minutes here. So my last message to you is to consider and create your family plan often if you're kind of in that early stage. There are many resources that are available to you, and our website houses a lot of the resources that are out there. We try to collate all of those together for physicians. And I encourage all of us to contribute to a supportive culture for all individuals to achieve their personal goals. Thank you very much.
Thank you so much, Dr. Dason. I'm going to just open up the floor to some questions if anybody wants to unmute. In the meantime, I'll just ask a couple of questions that came in through the chat. The first one was asking about what the link is to the website. I think throughout your presentation, you were referring to a particular one.
Yeah, it's I'm going to type it in the chat here.
Okay.
www.familyplanningfordocs.com.
Okay, perfect.
And I think my last slide here is just a QR code to get to the website if you'd like to see it.
Perfect. The second question comes from Jennifer. She asks, can you speak to what to do with the child saving, i.e. piggy bank, other than RESP? Is there anything other than a high interest saving account?
Some people will open TFSAs, but they have to be in your own name. So you can't open anything in the child's name. Other people will figure out ways to put money aside in their corp or think about real estate investments, but that can be a bit more challenging as well. So that would be some sorry, I'm not so well versed in all of those options, but those are some of the things that people will think about.
Okay, thank you. Another question was, do you know if you can take more than one paternal leave in residency?
Yes, absolutely.
Okay.
Yeah, I took 2 leaves in my residency.
Okay.
But basically you have to have a certain amount of time back to work to earn the EI again. So it's the same idea, like you have to work 600 hours to like reactivate your EI or whatever it is. So there has to be some time worked between leaves.
Okay.
But you still access the top up again. So like you still get the Paro top up again, etc.
Okay, thank you. And then in terms of for OPIP, can you use the $7,000 from the medication to other things within, for example, like IVF, sperm donor, etc.?
My understanding is no. My understanding that it's medication only.
Okay.
That may change with time. Like I'm noticing a lot of the insurance options are changing. Like a lot of the big banks now are actually offering, like if you have spouses or partners that are in other groups, you should look into their insurance because a lot of them are now offering different coverages. So they're saying, $20,000 for all fertility treatment plus medication. There's different stipulations. There's lifetime stipulations. There's yearly stipulations. So OPIP right now is medication centric. I do think that was one of the things that came up. I think it came out in the term 3 arbitration thing through OMA, if I'm not mistaken, that they wanted to start to increase some of those benefits and looking at those things again. So we might see changes in time. But right now that's what it is.
Okay, strictly medication. Thank you. Another question is, can daycare or private school costs be expensed through corporation?
No, my understanding is they cannot. It's a personal, like childcare is a personal cost, and similar to the childcare benefit, it's like paid personally. So I think that question has been like asked many times in the physician financial independence group, and I know my accountant says no as well. I think it all has to be personal.
Oh, personal. Okay. Another question from Stephanie Zhao is, do you have to apply for PPLBP immediately when you go on leave, or can you request payments start 1 month later?
You do not have to apply immediately. You can actually take it non-consecutively. Like it has to be within a year of the child's birth, but you can take it non-consecutively 2 weeks at a time.
Okay.
So you can actually like do 2 weeks off and then go back to work for 2 weeks and then take it again. That's my understanding from it. I will say that people find the form to be a hassle, so I don't know if it's like harder to kind of fill out that form if you're doing that. But yeah, I don't think it has to be within a year of the child's birth, and you can do it in 2-week increments.
2 week increments. Thank you. I think that's all the questions that I see. I personally enter everyone. I don't know if Adriana, if you got any specific questions either.
No, I'm okay on my end, just taking all the notes.
Okay, perfect. Awesome. Another question, any recommendations for breast pumps? Dr. Dason.
Yeah, invest in either a wearable one. So there's, again, it's on our website. There's actually a breastfeeding section
Mm,
with links to all of these, but there's an LV one, which is wearable. There is a Willow, which is wearable. You have to order them from the States, but that allows you to get more work done if you're trying to like pump at work. You can walk around the hospital in them. You can go see patients in them if you want. Or a hospital grade one. So the ones that are typically Mandela, but the higher grade ones, and Spectra, although that one you have to order from the States. Those are the typical breast pumps that people will use these days.
awesome. Great. Perfect. I think that's everything.